At the end of the day, the bottom line is there isn't a whole lot that is new in the management of complex perianal Crohn's disease. The most important message that I would have to you, and we certainly see this at the university, is a very close partnership between my gastroenterology colleagues, Scott, Anita, Tim, and others, many of you in the audience, and the surgical options so that we make that very integral to decision making. That's one message. The second message is getting the patient in the best shape possible to do well with surgery. And I suspect that the perspective of surgery being a failure mode for the treatment of IBD, this type, and the last topic that Fernando talked about, is often because the patients are in such bad shape that by the time they have surgery, they are inevitably going to have complications. That's been a big change in my practice lifetime, that we are seeing patients generally in better shape and making a decision. And just as a comment about the last topic, the one point that I didn't see is if a patient comes in with a history of really struggling and then gets admitted and struggles and has a quasi-response, that's quite different from somebody who comes in having done reasonably well or not receiving any medical therapy, crashes and burns, gets admitted, and then gets urgently treated. Those two categories really determine how they perceive surgery, and often surgery in the patient who's been chronically ill is a godsend for them because they put on weight, they feel well, they can get out, they can participate in family, social life, and get back to work. So some important perspectives.